Yeah, start countdown. Good evening, friends. Welcome you once again to a brand new episode of GICS Rapid Journal Review. PCI is one of the commonest procedures which is performed in patients with symptomatic coronary artery disease. And it has seen significant changes over the past few decades, from a time of bare metal stents to the drug-eluting stents, and nowadays the even newer stents with very different drug release facilities or drug release mechanisms. The outcome of PCI has also changed drastically and dramatically for good. But once upon a time, when dual antiplatelet therapy was almost considered as a sine qua non in patients undergoing PCI, things have changed significantly over the past decade or so. Tonight, we are going to discuss a recently published journal in the New England Journal of Medicine, the Target First trial, which seeks to compare this de-escalation from dual antiplatelet to a single antiplatelet over 1 month, the Target First trial. There has been previous trials, the Target DAPT trial, etc. And we are going to listen more into this trial and before we have a discussion. And tonight we are joined by our expert member is Dr. Safal, who is a professor of cardiology from GB Pant Hospital, New Delhi. Welcome you, Safal. We are joined by Dr. Kapil Dev Soni, professor of critical care medicine at AIIMS, New Delhi. Dr. Ajit Kumar, who is also the head of critical care at Aster in Bangalore. We are joined by Dr. Sagarika Panda, who is also an associate professor of the Department of Critical Care Medicine at IMS and some hospital in Bhubaneswar. And the presentation will be done by Dr. Nipun Velawar, who is also the DM resident in some hospital and IMS in Bhubaneswar. So without wasting any further time, I would request Dr. Nipun to present the journal.
Sir, good evening to all respected consultants. I am Dr. Nipun Yalawar, DM trainee in IMS and some hospital. Today, I will be presenting a journal club on recently published article in NEGM. The topic is the early discontinuation of aspirin after PCI in low risk acute myocardial infarction. It is a target first trial. My moderator is Dr. Sagarika Panda, ma'am, associate professor in CCM, IMSM some hospital. I would like to start my presentation by stating the current guidelines on DAPT use, the European Society of Cardiology and American Heart Association. The default DAPT duration after the PCI in both the groups in acute coronary syndromes is around is 12 months, and in chronic coronary syndrome it is 6 months. And in high risk, high bleeding risk patients, the early stoppage of the DAPT around 1 to 3 months is suggested by the ESC group, and according to AHA, it is abbreviated DAPT strategy as per the acceptable high bleeding risk. The monotherapy according to the ESC can be clopidogrel is given, and according to AHA, the ticagrelor monotherapy can be continued. This is a concise slide showing the key trials of early decontinuation of the dual antiplatelet therapy. It consists of STOP DAPT2 trial, Smart Choice, Willide, and TICO. These trials shows the heterogeneous populations like stop DAP2 shows the mostly stable CAD patients. Twilight shows the high risk PCI patients. TICO shows on ACS only patients. And among these studies, the common is a early discontinuation of DAPT at around the 3 months. So there is a knowledge gap. As these studies shows, aspirin stop around 3 months. The most of the evidence is from Asian cohort and very limited from the European and Western population. There is a underrepresentation of low risk acute myocardial infarction with early complete percutaneous intervention and modern drug eluting stents. So key uncertainties are: is 1 month aspirin withdrawal is safe in acute myocardial infarction? Can P2-vital monotherapy preserves the ischemic protection while lowering the bleeding risk? The objective of study is to evaluate whether P2 vital monotherapy after 1 month of dual therapy is non-inferior to 12 months of dual therapy in patients with low risk of acute myocardial infarction who underwent complete revascularization with contemporary drug-eluting stent. The design, it is a multi-center open label randomized control trial conducted between March 2021 to 24 across the 40 centers in Europe. They enrolled 2,246 patients and randomized after 1 month of uneventful DAPT into the two groups, P2 white monotherapy versus the 12 month of DAPT. And they took the follow-up at interval of 6 months and 12 months. They included the adult population with age more than 18 years, presented with STEMI and NSTEMI, who underwent the complete revascularization with contemporary drug-eluting stent, and revascularization completed within the 7 days of MI with no complications during PCI, and completed 1 month of dual therapy without ischemic or major bleeding events before randomization. They excluded the patients excluded the patients with high bleeding risk who received the fibrinolysis, active bleeding, liver cirrhosis, thrombocytopenia, and also excluded the patients with high ischemic risk like complex PCI, left main coronary artery disease, total stent length of more than 80 mm, severe coronary calcifications. The primary outcome of study is net adverse clinical and cerebrovascular event at 11 months, which includes death by any cause, myocardial infarction, definite or probable stent thrombosis, stroke, major bleeding calculated by BARC score of type 3 or 5. The main secondary outcomes are clinically relevant bleeding of BARC score 2, 3, or 5 at 11 months. The other pre-specified outcomes are device-oriented composite endpoint, patient-oriented composite endpoint, the major adverse cardiovascular events, and serious adverse events. The statistical analysis, the sample size was calculated assuming the event rate of 3.5 in DAPT group versus 2.5% in monotherapy group. With power of 80%, the alpha one-sided alpha of 2.5% needed sample size of 1908. The non-inferiority margin of 1.25% was decided. The hierarchical testing, first test non-inferiority. If achieved, the proceed to the test superiority for the bleeding outcome. The primary analysis was done by intention to treat and sensitivity analysis by per protocol and as treated analysis. The flow diagram shows the initially they enrolled 2,246 patients, out of which 304 patients were ineligible due to 213 were non-adherent to the therapy, 86 withdraw the consent, and 5 died. So ultimately 1,942 and population underwent the randomization into two groups. And P2 white whale monotherapy and dual therapy. So in monotherapy group, there were 961 patients, and at 6 months of visit, it is 93.9% were found to have adherent to the treatment, and 7% discontinued. At 12 months of visit, 87.5% were adherent to the treatment and 7 discontinued the treatment. And in dual antiplatelet therapy group, 981 patient population was present. At 6 months of visit, 96.8% patient were adherent to the treatment and 88.8% were adherent to treatment at 12 months of visit. The results, the baseline characteristics were same in patients with the mean age of 61 year, and 78% patients were male patients with equal distribution between STEMI and non-STEMI, and hypertension was the major medical comorbidity present of 38.9%, and complete revascularization was there. And these are the baseline characteristics. The primary outcome, the net adverse clinical and cerebrovascular event at 11 months showed the event rate at 2.1% in monotherapy versus 2.2% in DAPT. The difference was minus 0.09% with confidence interval of 1.39 to 1.20. The upper bound of this confidence interval is well within the non-inferiority margin of 1.25. So it meets the non-inferiority criteria. So this Kaplan-Meier graph shows the blue line shows the monotherapy group, and gray line shows the antiplatelet therapy group. At the 11 month of interval, these two curves almost merge with each other, showing the similar incidence of point minus 0.09% with for which meet the non-inferiority criteria. These are the secondary outcome, the individual component of primary outcome. In this, there was no significant no significance was found, but the death from any cause was 4.4 in monotherapy group versus the 2 in the dual antiplatelet therapy group. The main secondary outcome is a BIS scoring 2 to 5. Event rate was 2.6 in monotherapy group versus the 5.6 in the dual antiplatelet therapy group. The hazard ratio was 0.46 with confidence interval less than 1. So it show statistically significant with p-value statistically significant, showing the superiority of monotherapy or dual antiplatelet therapy. And the main second, the Kaplan-Meier graph shows the two similarly the monotherapy and dual therapy graphs are separated from initially only, and they diverge as the duration progresses, showing the bleeding risk is less in the monotherapy group. The subgroup analysis, the primary outcome, there is no significant difference as a difference found in the subgroup of the patients like age, sex, and all were aligned to the center. So there was no significant result found. The main secondary outcome is in patients with age less than 75 years old, male patients, and STEMI patients with single vessel affected patients. And in these patients, the monotherapy, there is a hazard ratio less than 1 with the confidence interval less than 1, showing the favoring the monotherapy group. The adverse event, the total of 144 serious adverse event were reported in 108 patients, approximately 11.2% in P2Y12 inhibitor monotherapy group, and 157 serious adverse event were reported in 122 patients in dual antiplatelet therapy group. The discussion, the key finding, the stopping aspirin at 1 month and continuing P2Y12 inhibitor monotherapy was non-inferior to dual therapy in terms of net adverse clinical cerebrovascular events, and also led to 54% reduction in clinically relevant bleeding. The strength of study, it is a multi-center RCT conducted in 40 centers across the Europe, and it has maintained strict low risk acute myocardial infarction population with early complete revascularization using the modern drug eluting stent. The high procedural risk and use of a potent P2 vital inhibitors with guideline based therapy. Endpoints were robust and the excellent adherence to the treatment was there, and non-inferior to ischemia plus superior for bleeding reduction. The consistent results across the subgroups. The limitation of study, although non-inferiority was formally achieved, the lower than expected event rate reduced the observed effect size and effectively widened the relative non-inferiority margin. The telephonic assessment of follow-up may underreport the minor events. Exclusion of high bleeding risk limits the applicability to the world population. The geographical restriction was also there, and it is an open label design, so potential reporting and management bias was possible, and a short follow-up outcome beyond the 12 months remain uncertain. The conclusion of study, the result of this trial showed the among low risk patient with acute myocardial infarction who had undergone the complete revascularization had subsequently received 1 month of dual antiplatelet therapy. P2Y12 inhibitor monotherapy was non-inferior to the continued dual antiplatelet therapy with respect to occurrence of adverse cardiovascular or cerebrovascular events, and resulted in low incidence of bleeding events at 1 year than dual antiplatelet therapy. Similarly, there is another article published in NEJM recently, the early withdrawal of aspirin after the PCI in acute coronary syndrome. The population was the patient with acute coronary syndrome, STEMI, and unstable angina underwent the successful PCI with at least one drug eluting stent within the 4 days of hospitalization. The population was 3,410. The intervention was the early discontinuation of aspirin after PCI and potent P2Y12 inhibitor monotherapy started within the 4 days of PCI. The comparison was the standard dual antiplatelet therapy was like aspirin and potent P2Y12 inhibitor for 12 months. The primary outcome shows the composite of death, MI, stroke, or urgent target vessel revascularization. The monotherapy event was 7%, and in DAPT is 5.5%. So the conclusion of the study was the immediate aspirin withdrawal with P2Y12 monotherapy did not demonstrate non-inferior to the DAPT for ischemic outcomes. The monotherapy reduced bleeding but had numerically higher ischemic risk, especially early post-PCI. Thank you.
Okay, thank you, Nipun. It was a nice presentation.
Thank you,
Before we move on, can you stop sharing your slides? Yeah.
Yes.
So before we move on to our main discussion, I would like to request since Safal is there, and it would be useful for all our intensivist friends to get some technical inputs, because that will clear some doubts. Safal, there was a time when primarily we used to think more about instant thrombosis. And that is why dual antiplatelet was almost, although usually in bare metal stents, some people used single platelet, but more or less everyone tried to use with the assurance of drug-eluting stents. And that those days we had only aspirin and clopidogrel. Now we do have newer stents, and this study was on that Firehawk, the microport
Yeah.
device, and we have the Prasugrel, we have Ticagrelor. So we have. So what is the reason that we think confidently about reducing the regime from dual antiplatelet to single platelet? Is it the better devices or the more confidence with the newer drugs?
So first, I'll break up your question into two parts. One is that, as you asked, we confidently think of reducing the antiplatelet quick. So it is a hot topic. There are multiple trials that have come up. I think the presenter has very beautifully showed Twilight, TICO. In fact, bleeding is more of a concern among Southeast Asians. But as of today, we are still not confident that we can withdraw that DAPT at 1 month. As he rightly showed, there's conflicting data. So as of today, medico-legally also, the guideline is clear that post ACS PCI, it is 1 month of DAPT.
So, but this study
Now,
only surrounds the low risk, the patients
correct, correct. But as of now, this is a study, and a study which had lower number of events than what they had taken for calculation of sample size.
Yes.
So really the evolution now is, and as it is reaching the guidelines, so current evolution is high bleeding risk. We are reasonably sure that at around 3 months, let us go back to a single DAPT. So let's go back to a single antiplatelet. Also, once upon a time when we used to withdraw the antiplatelet, it was invariably clopidogrel that we used to withdraw. Now, gradually the consensus is that you have to withdraw one, you withdraw aspirin. And the reason for this developing is one, thinner struts, the new stents that are coming, they are now, the struts are 60 microns, 70 microns. Also, studies which have used intravascular imaging may have given slightly better post-dilatations, better results, and quicker endothelialization. Most of these studies are with specific stents, as you mentioned, this one with Firehawk, there's another with Ultimaster, and there are 5-6 such stents with whom. So if we really are planning very short DAPT, to the extent possible, we should try to stick to the stents with whom these studies have been done, which is not one, which are 5-6 odd stents. Number two, we have come away from the clopidogrel. In this study, if you see 95 to 96% were ticagrelor or prasugrel.
Yeah.
So that single more potent P2Y12 may be somewhere equivalent to aspirin plus clopidogrel, what they were giving us together. So the change in the stent strut thickness, possibly better finishing touches to the PCI with intravascular imaging, and the P2Y12 becoming more potent. These are things where we are actually thinking of reducing antiplatelet, but again, sir, I'll emphasize, we are thinking of routinely. We shall
Yeah, I
not
get
be.
your point that nothing should be taken absolutely from the inference of one study, and there are more studies to look for. Kapil, I want to ask you that in this study, is this non-inferiority margin of 1.25 really good, or is it something to be doubted?
So if you look at the paper, the authors have actually given the rationale. They looked at the previous trials and based on that, and also they did some piloting in their own centers. And based on the consensus, they decided to keep the non-fitting margin as 1.25. So they have given the rationale. There is always a debate how much non-inferiority is acceptable. Means how much worse outcome are unacceptable and acceptable. So non-fitting margin, there would always be debate. It has to be justified. They did some pilot study in their centers. They also looked at the earlier trials. Based on that, they reached up to 1.25.
So this
But
pilot
remember,
study, yeah, it was not there. They have
but
not mentioned about it in the
no,
supplement.
So if you look at the methodology where they have given rationale, their 1.25 was based on their own results, their own
Yeah.
practice results, which they were following.
Exactly. So there is a variation in the population. Sagarika, do you think that this incidence, there are two things only, one is thrombosis, another is bleeding. that our Asian population, as was mentioned by Safal also in a nutshell, but the Asian population, or if you look into your population in your state, do you think the Asian population or Indian population to that extent, because in India we had the in-depth study also, they have more risk of bleeding following this dual antiplatelet, Shagarika?
Uh, yes, sir. What we are actually, sir, observing in our center also, like patients are coming with bleeding after this with a dual antiplatelet therapy, sir. Like GI bleeding, or maybe that is not very fatal or life threatening, but GI bleeding or like hematuria, and some patients also with ICH. So the thing I want to mention here, these things are non-inferiority of this 1.25. This is maybe like statistically, that is they are like justifying the statistically it is 1.25%. But the thing is that clinically we have to again see whether we can accept that much of risk of increasing that 1.25%. And here also in this trial, the sample the event rate was very less than the expected, so obviously it will increase that
It will
margin
put a
of.
question mark to the overall conduct of the study. That is right. Yes, Safal, how do we differentiate or classify in patients who have in medium risk, low risk, of high risk of bleeding? The genetic basis may be one reason, but what are the others?
So, clinically, practically, what we take are the HBR factors, and the HBR factors are advanced age. They've what they've taken for their trial also they have discussed advanced age, low body weight, anemia, CKD, chronic liver disease, past history of bleeding. So these are the factors which we actually take for HBR. And so,
If you have seen the chart, two of the in that subgroup analysis where the diamond is to the left side, one is the age in which the diamond is to the either side of the of midline, and another is the multiple lesions in a single vessel. Now, how do you define your device success, Safal, when there are multiple lesions in a single vessel? Like there can be one proximal lesion and one distal lesion in the LAD, and your stent with the stent you may fail to negotiate through the proximal lesion, but you may later use the device for your distal lesion. Now, how do you define your device success?
so one is device success, one is procedural success. So device success, if I have chosen a target, and if at that target, I suppose I choose that I'll only do the proximal lesion, for instance. And at the proximal lesion, I am able to achieve less than 10% residual stenosis. I will say that device-wise, it was successful. Coming to procedural success, ideally what should be done, which is practically not done anywhere in the world, not commonly done, is that the final FFR, that's the fractional flow reserve that's calculated. Final FFR after stenting, the final FFR of the vessel should be more than 0.9. So that is how we define it. But practically what we see that angiographically, we have not left any stenosis more than 50 to 70%. Importantly, so this, as they have highlighted, they have taken complete revascularization. Now,
Yes.
complete revascularization is important because we have studies like the DAPT study, which said, why not prolong DAPT to up to 30 months? And there it was shown to be beneficial, but it was beneficial not for the stented vessel or for the stented lesion. It was beneficial because it reduced acute events in the residual vessels that we left out. So that part they have tried to negate. So, and a large majority of patients in ACS, practically what happens is that we do the concerned vessel and the remaining we leave on medical therapy. So there again, you cannot be thinking of shortening the, that's out of the purview of this trial.
Yes, very right, very correct, Christopher. Fully agree with you. Kapil, when you look into this study, you find that it's a very well conducted study to the point that among the numbers enrolled to the number which was finally randomized, there is hardly much of difference. So a good number. And they have also the baseline characteristics are matching, they're similar. But do you think that exclusion factors, when you look into it, that a lot of patients have been excluded, and that in fact it's an impediment to the results of the study?
So if you look at the target was 2,246 patients which were actually enrolled, and out of that, many were excluded. But if you compare with total population who underwent randomization, they were still able to randomize around 1,900 patients, right?
Yes.
After that, there were very few exclusions based on discontinuation, died, or whether they
Those were
they
few.
withdraw the
Those were
consent.
few.
Very few. Those were few, and they were almost equal in both the arms. So once they were randomized and after they were excluded, it will not make much of a difference in final analysis. But importantly, if you look at generalizability, the population is becomes very selective. I mean, they were low
Exactly.
risk with complete revascularization. So the general applicability is questionable, but yes, the population was very selected.
Yeah, so that is something which is assuming, because in real life you are not able to categorize so strictly, and if you find that the patient has a medium risk or a low risk. Now, Shagarika, when you see these complications in which they have seen the primary outcome, which was a composite. Acha, Ajit is there. I can take.
Yeah, tell me. Yes, yes.
Yeah, Ajit, since you are there, I will take this question to you.
Yeah.
If you look into this composite outcome, which included death due to any cause, alongside others, stroke, in-state thrombosis, do you think that this composite outcome is a good a measure of the device failure, or the a patient-oriented outcome, or a device-oriented outcome to that matter? Or do you think that unnecessarily of these components, one component has more weightage, the others have less weightage or something? How do you attribute the use of this bundle?
So basically, in the Asian population, we are more concerned with the bleeding. So they are more. I mean, here we are measuring the bleeding events. We are measuring about the again ischemic events in the form of myocardial infarction, stroke, and all. So basically, it's a composite outcome. Everything taken together may not be the right thing to happen.
Yeah. So exactly. So you want to add anything, Shagarika? Whether this composite outcome is appropriate for this study, or we should have looked into individual outcomes to make simple.
For like individual outcome in this type of study where the events rate are actually very less, the expected was also very less, so individual we need a large sample size for that, and duration of study obviously will be like so for this type of study composite is actually statistically we can justify it.
So Edie, in your ICU, when you see bleeding, which type of bleeding you do see commonly? Is it the stroke, or do you see other forms of bleeding?
Like GI bleeding we are seeing, sir, most
GI
commonly.
bleeding you are seeing. Okay.
Yes, sir.
Yes, Safal. You want to add anything, Safal?
Sir,
In terms
actually,
of the bleeding, yeah.
with this bundle, this bundle has actually evolved over the past 5 to 7 years. Earlier, the DAPT studies, they used to tell us MACE, M for monkey, major adverse events, cardiovascular events separately, and bleeding separately.
Yes.
And invariably, the result was that if you increase the DAPT, the MACE was lower and the bleeding was higher.
Right.
And where did we go with this conclusion for the patient? We did not know. So over the past 3-4 years, this has evolved to a NACE, net adverse, where the bleeding is included along with the ischemic. So this gives us an overall weightage. And the bleeding, if you've noticed, it's only BARC 3 and 5 that they have included in the primary endpoint.
I was coming to that question next. Okay. Yeah, you go ahead.
And so the secondary that they have got superior anyway, that is bleeding alone. That in any study where you're reducing DAPT, you will get it. And that too based more on a BARC 2. So by and large, NACE is the standard now, because we have to tell the patient what is finally beneficial for you.
Exactly.
You cannot tell him choose a small MI or choose a small bleeding. We finally have to tell him what his outcome will be.
Yes. So Safal, when we look into the more delicately into the subject, you see, when you have your culprit vessels, is it possible preposterously to identify those vessels? Like these patients in the secondary outcome, if you see, there was not much of a difference between any of these. But in case of BARC 3 and 5, there were difference. So is it possible to identify in culprit vessels that which patients are likely to bleed by looking at the because atherosclerosis is a generalized process. I mean, sorry, not bleed, which patients are likely to have more thrombosis or the chances of less thrombosis for that matter?
When they've said they've not taken complex procedures, that's in their exclusion. So they have ruled out specifically some procedures like, and which is commonly ruled out, are bifurcation stenting. Very long length of stent. They have ruled out stent length more than 80 mm. So that means extensive disease. Left main bifurcation is almost invariably excluded from these trials because nobody wants a mortality risk there. So
Correct.
bifurcation stents, cumulative stent length, which is very high, and residual disease that we are leaving, and chronic total occlusions because they have a high tendency to restenose. These are the cases which are practically left out from these trials, including this one.
Kapil, in addition to the per protocol and the intention to treat analysis, they have also done as per situation. So now, what was the main purpose of doing such an analysis in the first place?
So I explained, if you look at the trial design, it was non-inferiority for primary outcome, and for bleeding they
Superiority
went for
for science.
superiority, right?
Yeah.
So when you do non-inferiority trials, the most of the regulatory bodies, they say that you need to show non-inferiority in both per protocol analysis as well as superiority analysis, and as treated intention to treat analysis and as treated analysis. So for non-inferiority trial, the more the trials have become more reliable if they are able to show the non-inferiority in both intention to treat as well as per protocol. As treated will have very mix of population, means they try to simulate the real world situation, so that takes into account. So there are three types of analysis.
So that is the important. I think that you have rightly highlighted that they want. But do you think, Ajit, when you
Just hold on. But if you look at this trial was able to show non-inferiority in intention to treat analysis, but for per protocol analysis, which is
it
more
was not.
credible, credible for
the-
non-inferiority, they were not able to show. Now this
Exactly.
is because they falsely concluded this is called falsely concluded non-inferiority, which is type 1 error. If the power is less, which is 80%, and the event rate is also less, then it's very easy to conclude non-inferiority just based on small event rate.
Exactly.
So
exactly.
the per protocol here actually does not showing the non-inferiority. So what is mentioned was like the sample size is small. So that could be the reason, the statistical power is not achieved. That's what
No, the sample
all
size
this.
was achieved. The
No, but
sample size of 1900 was
per protocol, because of reduced sample size, that is one, the others were mentioning, if I'm not mistaken.
no, per protocol is that once
The
randomized
statistical power is not achieved because of reduced sample size. That's what the authors are mentioning. I need to just see that once again. Yeah.
anyways, but the point is that what they had to show non-inferiority in both, which they were not able to show.
See, yeah.
So that was now coming to you, Ajit. When you look into these complications, particularly when they occur, what are your immediate concerns when the patient has bleeding following PCI? Although the numbers have gone down largely, what are your immediate concerns in the ICU?
When the bleeding is happening.
Yeah.
So bleeding is happening mean if it's a massive bleeding, mean obviously whatever I'm
But
trying.
massive bleeding usually takes time. So initially, when the patient has a bleeding, it is detected by the following in the
So if it's a minor bleeding, mean I can just wait and see. But obviously, I'm reluctant to give any measures to prevent some kind of a tranexamic. I mean, kind of the thrombotic medicines. We are very reluctant to give anything which can reverse the bleeding. So we are very much concerned. So we will try to be as conservative as possible.
Yes, absolutely. Shagarika, in your place, when actually you look for cardiac surgery backup in these patients when they have bleeding? Although no surgeon is going to operate without a DOT consent in these patients, but when do you look for?
Yes. So just like intracranial bleeding with a mass effect.
No, I'm not talking about intracranial. I'm talking about the other sides, because intracranial you'd have to depend upon a lot of other factors.
Yes, sir. Yes, sir.
Say GI or any other such.
Yes, sir. So we can do endoscopy, and we can control the source. We can
Your IR, you depend more on your intervention radiologist for
yes,
that
sir.
matter.
like some ligation or some endotherapy we can do. And obviously
Yeah.
we have to seek the cardiology consultation immediately. So like which drugs we can continue safely at that time, or we have to like withhold all the antiplatelet and drugs.
Uh-huh. So what are the means, how much has been this decline in this bleeding complications with the use of ticagrelor and prasugrel realistically, other than what is reported in the studies, Safal?
So, to be very plain, there is no reason to believe that because as of now, we are using ticagrelor and prasugrel in combination with aspirin. Monotherapy has not yet picked up and is practically not yet in the guidelines. Monotherapy, if at all, is after the aspirin duration. So really, can I claim that the bleeding has reduced? No. But the catch there is that the thrombotic events come to the cardiologist. And the cardiologist is only interested that those thrombotic events should not come to him,
No,
frankly.
but definitely, Safal, I would disagree to a point that definitely bleeding has reduced, because it is not that it once suddenly it has come down from 12 months to 1 month. There were studies at 3 months also. People have found that after 3 months, probably dual antiplatelet can be stopped. And after encouraging results, they have resorted to Trigat after 1 month. So this has
We are
been
talking.
over.
So we are talking about DAPT versus single antiplatelet,
Correct.
right, sir? Within that 1 year period. So in practice, sir, post PCI, country over in cardiology practice and in with the guidelines also, most cardiologists continue with their DAPT, except in high bleeding risk patients or a patient who starts having warning signs like ecchymosis, etc. We continue with DAPT for a year. So really that reduction in bleeding that needs to come, that will only come when 90% of our patients will be on monotherapy. Then we'll be able to compare. So
Yeah.
it is a standard clinical practice even today is 1 year of DAPT, at least after ACS PCI.
So forgetting about this study, if the patient has a history of prior bleeding, and you know that this patient, so what are your other options you are available to you?
Yeah, so that patient that either he's had a prior bleeding or I know he's at a high bleeding risk, that patient is approached differently in 2 or 3 ways. One, I will only use those. First, I'll try to keep the procedure simple. If I can get away with one stent, I'll avoid any bifurcation. If at all I have to do a bifurcation, I'll be using drug-eluting balloons at some places to reduce the residual metal so that planning starts from intra-procedure. The stents, I will use the thinnest struts. Preferably, I will use those which have proven to be beneficial in these short DAPT studies. And with that stage, we frequently stop DAPT at 3 months. Frankly speaking, at 1 month, today we are only stopping DAPT in those patients who are on anticoagulants. Those patients, within a month, within 4 weeks, we shift them to one antiplatelet, which is clopidogrel plus apixaban.
So do you see any role of oral anticoagulants coming up in future?
Only for PCI. So one is as the population ages, including the Indian population, as we live longer, atrial fibrillation is very common. It becomes more and more common with age. So
Correct.
this group of requiring anticoagulants plus an antiplatelets is increasing because the age is the biggest risk
Sure.
factor for them. But per se, only in post PCI settings, there was a trial with low dose rivaroxaban, etc. But that is practically we use it, says for somebody who has a graft and then graft thrombosis, and that's too much of a thrombotic load. In some of these patients, we are using it, but role is limited. Only for post PCI.
Ajit, you are there?
Yes, I'm here. Yeah.
Yeah. So Ajit, when you have such an encounters with, say, intracranial bleed in a patient who has undergone a PCI, so how do you think that this bleed might worsen further? How do you gauge the severity that this bleed might increase? Not every bleed is serious, but some bleeds turn really bad, because atherosclerosis is a systemic disease. If a patient is having an atherosclerosed vessel in the heart, he is likely to have a similar vessel in the kidneys, in the brain, everywhere. So how do you know that this bleeding is likely to worsen fast? Do you have any?
For that purpose, I would like to take a neurosurgeon and neurology support to decide upon that. So I'm not very sure we can just, especially when this, this antiplatelet induced bleed and how it is going to behave. I'm not very sure about that. Yeah.
Okay. So there are a lot of patient-related factors also which come into play, irrespective of the type of the stent or the type of the drug or the type of the antiplatelet used. Which are the common such patient-related factors which finally determines the occurrence of thrombosis or bleeding? Yes, Sagarika, do you have any observation on that based on your experience?
So like which was I think
Like diabetics, this, that, septic, or
other comorbidities
CKD,
like CKD patients or like uremic
cirrhotic.
patients where the like the platelet dysfunction is there, or like cirrhotic patients. So with these comorbidities, it is already high risk. So with use of the dual or already bleed, like having ICA, so maybe the risk is high for further bleeding.
so Safal, if a patient is already diabetic or patient is having liver disease, how will you plan your antiplatelet therapy?
So diabetics have a higher thrombotic risk per se. And there is some, so if a diabetic is at low bleeding risk, say I have a 50-year-old diabetic who weighs around 75 kgs, I would probably, and I'm doing a complex procedure in him, he will be the ideal patient for prasugrel, which is the most potent of these three per se. And on the other hand, if it would be like a chronic liver disease, I would quickly, possibly I would use either clopidogrel or ticagrelor and quickly shift, say within a month. Even if I don't stop my DAPT, I would shift from 90 mg ticagrelor to 60 mg. So that way.
So is there a possibility of interchangeability of this antiplatelets over a period of time, that if you're using, or is it something binding that if you're using ticagrelor, you will have to use ticagrelor, you can't change to prasugrel? So on what, how do you shift gears?
Yeah, so we frequently have to shift the antiplatelet, most commonly ticagrelor, because in a significant proportion of patients, it causes dyspnea. So that is one of the antiplatelets that is very frequently switched over in a week. If it's causing dyspnea, say in 10 patients, in 7 it will resolve by a week. So we tell the patient that for 1 week it is drug related, you'll get okay. Those 2-3 patients who remain who are not able to tolerate it, we shift. So if the PCI is very recent, we reload. Suppose I have to shift the patient to prasugrel. If the PCI is less than 1 month, I will reload with half dose of prasugrel instead of 60 mg, 30 mg. When the last dose of ticagrelor was due, and then continue the normal antiplatelet. If the PCI has been for stable disease and more than a month has passed, no reloading, I'll just stop ticagrelor, and where the last dose was due, I will give my second antiplatelet that I've shifted to.
And which are the patients on which you will stick to aspirin and will trust your aspirin more than others?
So practically now the science is going towards that you have to give one antiplatelet, you give one of the P2Y12.
Oh.
Among the P2Y12, there has been some concern, but not clinically proven, that among Indians, possibly clopidogrel resistance is higher than in the West. So maybe one antiplatelet between tica and prasugrel, and most commonly, given its lower bleeding risk, possibly ticagrelor.
So we have really running out of time, and we are coming almost to the end of our show. So I would like to ask by asking the same question I will to everyone, and that I will start with Shagarika, that what are the two important messages that we get from this study in terms of PCI, bleeding risk, thrombosis risk, and antiplatelet therapy? And I will come with the same question to everyone. I will end with Safal. Yes, Shagarika.
With like evolution of as we're using the drug eluting stent, and bleeding risk are, we are also seeing the older age patients and bleeding risk are high. So like we can select a very low risk of patients, like so many criteria they have given, like complete revascularization. If we are able to find this, then we can use that monotherapy.
So you think that monotherapy has a place,
Yes, sir.
has made
Very
its place
very narrow group of patients, sir, actually.
in a narrow group? Yes, Kapil. 2 or 3 important messages that come from this study.
So, so I think first of all, I will not talk on basically cardiology point of view, Dr. Safal would be able to tell you much better. What I would tell you is about the robustness of the study and the study non-inferiority design. For all the audience, a non-inferiority design is little tricky to understand because it's just a simple reverse of superiority trials, and one must understand what are the limitations, and there is always a possibility of falsely concluding non-inferiority if the power is less, which was 80%, and the event rate is small. So in such studies, you need not to change your practice. You need to look at the other studies and the future trials as well to actually change your practice. So one study you will not be able to change the practice.
True. Ajit, you are there?
Yeah, so yes. So this is a single country, if I'm not mistaken, single country, multiple sites, 40 site study. And they are used, obviously the low risk, myocardial infarction with the early complete revascularization. They're used a particular stent, that microport. I'm not an expert in that. I don't practice cardiovascular
Fire off.
management.
What
Yeah,
is
I
the
know, I
common-
know. So basically the microport stent with some rapamycin eluting stent has been used. So with that stent, with the, in that particular country which is sustaining, they did the study, and obviously there is a narrow thin margin. I can say that, some sort of non-inferiority that's in the,
No, rapamycin is quite common, I think, Ajit.
rapamycin, is it?
Yeah.
Everolimus or something,
Sirolimus.
Yeah, those kind of stents are this
Sirolimus.
rapamycin. So we are using the same thing. I don't know what kind of stent we use in India. So in that particular thing, based on this study, it may be too early to make a conclusion on that. Obviously here the intention to treat analysis only has shown the non-inferiority. The per protocol has not shown that. So it is too early to decide about at this point of time. I would like to continue the conventional thing at this point of time because it is too early, especially when it comes to the cardiovascular system. Once something happens, So
Yeah,
I think it's
thank
too
you. I
early.
get your point, Ajit.
Yes.
That 1
Yeah.
month is probably too early. That's what you mean.
Yes.
So final message, Dr. Safal.
I
The
would
important from this study.
agree with what the other panelists have pointed out. One, this study itself should not be taken as a practice changing study. Message one. Message two, if we end up with a patient who's not tolerating DAPT even within 1 month of this, we don't need to lose sleep. We know that yes, there is evidence that if we shift him to single antiplatelet, likely not much harm will be done, or possibly even no harm will be done. Yes, sir.
And Nipun, are you there? So I think I should ask Nipun, who is presenter today, that not any difficult questions, but two important new things that he has learned while preparing for this trial. Yes, Nipun, can you tell me one or two new things that you have learned while preparing your slides for this trial?
Sir, regarding the antiplatelet therapy, this monotherapy thing,
So
which
this
I
is something
studied
new to you.
recently. Yeah, sir. And
Okay.
sir,
Thank you. So thank you.
thank you.
Friends, it is indeed too early to predict that whether a single antiplatelet therapy is likely to stay for early or not. But definitely there is no doubt that dual antiplatelet therapy may not be required for as long as time that we were practicing before. But much more to come in the coming days. Until then, we should keep our fingers crossed. I thank once again to all our panelists, Dr. Safal, Dr. Shagarika, Dr. Kapil, Dr. Ajit, and Nipun for joining us. Be with us on the second and fourth Thursdays of every month for more such discussions on more hot topics of critical care medicine. Till then, from all of us in GICS Rapid Journal Review, Shubharatri, Shavar Khayat, good night.
Good night. Good night.
Thank you. Good night, everyone.
That's it.